It's not one person. It is an entire mindset to build stable institutions where none existed. To me, that is about hope. Health for all is the future.
And Partners in Health was formed.
We started finding these tuberculosis patients.
There was a big hole in the program.
They do not know what watches and clocks are.
They don't believe that we have an equal right to life.
The current Ebola outbreak is the world's deadliest to date.
This is the worst thing any of us have ever seen.
When we took the blame off the patients and put it on the system, everybody got better.
Everything we do was with the community and for the community.
Tout monde c'est monde. Si moi-même cap vivre jodi, am ta remè pour l'autre malheureux vivre tout.
Welcome, everyone. My name is Sheila Davis. I'm the CEO of Partners in Health, and so glad to be here with all of you today who are joining us as live, as well as those who will be following up and watching this after. So today you just saw a clip from Bending the Arc, which is a documentary that was made about Partners in Health and a small group of young heroes, some of which you'll meet today, who came together many years ago to address some of the inequities that we see in the world. Today, during the COVID-19 crisis, we're in a very similar circumstance where we see that the estimations are that it will still take us by 2023 before the majority of the world will have access to the COVID-19 vaccine for even part of their populations. This, unfortunately, is not a new phenomenon. During HIV, certainly TB, drug-resistant TB, we've seen that there's an inequitable distribution of pharmaceuticals, of diagnostics, of facilities, et cetera. And we've gathered a group today to look at and to talk about some of the key reasons why this continues to happen, and also some of the challenges we're facing, particularly with COVID-19. And hopefully as well to talk about what can be done to change and shift some of this dynamic so that we can strive for a more equitable global health environment for all of us. I'm going to briefly introduce all of the speakers at once, and I'm not going to go over their extensive bios, but please do look at them and see all the wonderful things that have been achieved, but want to spend the majority of our time jumping into this great conversation. You can go to the first slide. The first speaker who will be joining us in the panel today is Dr. Agnes Binagwaho, who is the Vice Chancellor and co-founder of the University of Global Health Equity. Next slide. Second is Dr. Peter Drobac, who is the director of the Skoll Centre for Social Entrepreneurship and one of the UGHE co-founders when he was with Partners in Health in Rwanda for many years. Next slide. Then we have Dr. Paul Farmer, who's the co-founder and chief strategist of Partners in Health, as well as UGHE's co-founder and chancellor. And last slide. We have Dr. Yong Kim, who is the Vice Chairman, Global Infrastructure Partners, and also one of the original co-founders of Partners in Health. So today, we can go to the next slide. Today, the hope is that we will have a very rich dialogue, and please do ask questions. You can ask questions by typing them into the chat, and we will try to get to as many of those as we can towards the end of our conversation. But wanted to start this off by some questions that have arisen through many key conversations, and then we can take the conversation from there and move towards a really dynamic way of sharing the expertise of these wonderful panelists. The first question is for Peter. And the question today is, when we look at a post-COVID-19 world, one of which none of us, I think, could have predicted what the world would look like a few years ago, the inequity of the vaccine availability is really being hung up by high-income countries, such as the US, such as the UK, where you are, inequitably having the vaccine for their populations. What barriers exist, do you see, for low and middle income countries accessing the vaccine, and any suggestions on how we can confront that?
Yeah, thank you, Sheila. Thank you for having me. It's great to be with all of you. I think that the pandemic has has deepened and exposed inequalities across our world and our society. And in like so many things, the vaccine sort of inequities in vaccine distribution that we're seeing now are both shocking and unsurprising because it's the oldest story around, right? You look at the history of modern medical scientific discovery, and whether it's AIDS treatment or hepatitis B vaccines or access to cancer care and screening, those who often need it the most and who are living in poverty are often the last to receive it, if ever. And there are a whole raft of reasons and excuses that are given for why that's the case. It's too expensive, it's too difficult, poor people don't have watches, all that stuff that we saw so beautifully illustrated in Bending the Arc. And many of those things are playing out now. One of the big differences, I think, with COVID-19 is that this has truly affected everybody. And in the US and other wealthy countries, as a result of really bungling the response early on, and we're sort of hit so hard that they're in desperate need of these vaccines. And so I think in some ways kind of true colors come out. It was different with Ebola, for example, where maybe there was a threat to wealthy countries, albeit a very small one. It was easier for everyone to sort of come together, if you will, to address that fight quickly. But what we've seen is that so many wealthy countries now are turning inward, and that's been evidenced. Just look at the data about countries that have gobbled up 5 to 10 times the vaccines they need to vaccinate their entire population, and they said we'll happily share these as soon as we've had our fill. That's a real issue because it's acting against everyone's self-interest. So to come back to your question, I think what's really important is that, as we've all heard so many times, none of us are safe from this virus until all of us are safe. If we were all sitting together saying, how can we as a global community fight this most effectively and put these incredible vaccines to good use, we probably wouldn't be giving vaccines to healthy 18-year-olds in America before giving them to frontline health workers in Malawi, as one example. We might be surging Pfizer vaccines to Brazil right now, where there's a dangerous variant on the rise, but that's not the way that we think. And I think in terms of what needs to change for the future, the COVID-19 is a dress rehearsal for 21st century problems. And I think this has exposed the fact that our mechanisms of kind of global governance and cooperation are not fit for purpose. And we have to think about ways that that we can work more cooperatively together to address threats, whether it's the next pandemic, whether it's climate change.
Thanks, Peter. The next question I have is for Jim, and the question is that there's widespread fear, I think, amongst many of us who work globally and otherwise, that the COVAX initiative will not be sufficient to address the needs in low-income countries. Could you explain a tiny bit about what COVAX is, as well as why do you think this is perpetuated, that we are in this circumstance related to COVAX? And how this is related to really entrenched social pathologies that we've been fighting for decades.
Thanks, Sheila, and it's great to be on with my very, very good friends and such incredible superstars, all of you in global health. COVAX is a great effort. It's an effort that's based in the experience of Gavi, the Global Alliance for Vaccines and Immunizations. And, Gavi is one of the most successful programs that we've ever seen. The increase in access to vaccines around the world has just been tremendous. I think we just all have to be very grateful, especially to Bill and Melinda Gates for setting this up. COVAX was the extension, the natural extension to say, well, we've got to have a consortium that makes sure that we have vaccines for developing countries as well. And so in talking to some of the people who are helping to run COVAX, the problem is just really supply. There was a whole bunch of vaccine that was made in India. And India just said, we need so much for our population, we can't afford to give it to you right now. And so the vaccines are just trickling in to COVAX. So it's the right idea. It was the right the right structure, but the vaccines just aren't flowing to COVAX. And so this has been extremely frustrating for the COVAX people, extremely frustrating for WHO. And it gets back to something that Peter said so well. It's just, this is a very difficult situation, because even after everyone's vaccinated in the United States, I think the question you have to ask yourself is, what will the United States, or frankly any wealthy country, do with its leftover mRNA vaccine, just as an example? And I just think it'll be very hard for them to say to their own populations, we're going to send it to Africa or anywhere else, because I think the question will be, well, what if there's another outbreak? What if we have lots more cases, and there are groups in that area where there are lots more cases that have yet to be vaccinated? Don't we need to save these valuable vaccines for potential future outbreaks? And so, normally, there's no normal. We didn't have this kind of situation in 1918. So I think an ideal situation would be some kind of global clearinghouse or a global authority that would say, here's how we're going to manage the overall effort to stop COVID-19. We had it for smallpox. And frankly, we had it for malaria, which failed. I mean, the malaria eradication effort failed miserably, but we did have a centrally controlled strategy. We had it for polio, but we just don't have it for coronavirus. We had it for SARS. I mean, I was at WHO at the tail end of the SARS pandemic, and we had very good global control. Now, the reason that worked and this didn't is in SARS, people don't start getting infectious until well after they're showing symptoms. So you could stop the spread much more easily than you can with a virus that starts spreading 4 days or so before people have symptoms. This is a different virus, but we did have a central authority, WHO, that was calling the shots. Again, in Ebola, we had a central authority that reacted very late. But there were only 3 countries in this case, and because the history of colonialism is so interesting, that kind of each of the colonial powers took responsibility for the country that they had colonized, and the effort and money that went in, along with Partners in Health, along with lots of other NGOs, got that Ebola epidemic stopped. But in this case, it's just unprecedented. The richest countries in the world are struggling with their own pandemic. So I'm extremely worried about where we're going. Now, we worked these problems out. Like, what about intellectual property? What about protecting first world markets so that the incentive to innovate it remains? We worked these problems out during the scale up of HIV treatment. Again, in 2003, I started working at WHO, and we figured out a way to not only make HIV drugs accessible to poor countries, but to protect first world markets, so that the HIV drugs are continually being made. They're still being made because there are several million people in rich countries that still have HIV. So new drugs keep getting made. We protected those markets, while at the same time dramatically 95% lowering of costs in the developed countries. So I don't think we have an intellectual property problem. We can manage the intellectual property issues. I think the challenge now is that we've got to start production of vaccines in the places that need it the most. And this is Africa, this is South Asia, and because even with the mRNA vaccines, the manufacturers have agreed not to enforce intellectual property. There's nothing holding us back, and it's a sad state of affairs, but it's also, I think, a reflection of just how severe this particular pandemic is. Every single, there's just a very tiny number of countries that feel at all comfortable with their pandemic response. And I can tell you that the countries that have even been most successful, Korea, China, Australia, New Zealand, they're also extremely paranoid, because now their task is not just to sort of, distribute vaccines. Their task has been and will continue to be to chase down every infection. And nobody feels that they're, quote unquote, completely on top of their pandemic. we're not going to be able to rely on the rich countries to be generous and give their extra doses to the poor. Unfortunately, we've got to start production facilities, but we're in a position to do that unlike ever before. I think we can do it. And I think there are many countries, even in very poor countries, who will be capable of making the vaccines.
Great, thanks. Yeah, very interesting in that sense in terms of capability and the assumption that there's not the capability to manufacture and keep up the scientific integrity of vaccines in other places, which obviously we know is certainly not true. Now, what I'd love to pull in Agnes and Paul into this conversation and have each of you talk just for a few minutes about kind of the historical and what has worked in terms of vaccine rollout for other vaccines and in countries where things actually have been successful. And we'll ask Agnes to talk about Rwanda and then Peter to talk about the UK. Then we'll go to you, Paul, for Haiti, and then back to Jim about the US. So again, what are there, are there any lessons learned and successes we can pull from as we start to address this as a global community?
I start, Sheila? So that's a great question. And first of all, I'm so happy to be with Jim, Paul, Peter, and you. Great memory, great fight, and we can see that we continue because we still need to promote. We have a so long way to go. And your question is interesting because vaccines are a great illustration of equity agenda for a country and also for the global solidarity. First of all, in a country, the equity agenda is demonstrated by bringing vaccine across all the country in an equal manner, but also globally, because the developing world cannot, doesn't produce vaccine, at least in Africa. So we need the global solidarity to have access to that. And Jim has talked about that when reminding all of us what Gavi is. But countries also have to dedicate a portion of the budget they have as a counterpart funds to get access. And it depends on the level you have in your development. So it's an equitable global agenda that we have with Gavi, a great one. And the history of Rwanda for vaccine, for me, I'm very proud to say that today, 90% of the children in Rwanda are fully vaccinated for 11 vaccines, and equitably across 12 quintile and across the country. And one of the vaccine, HPV vaccine, show how, in my point of view, a country should process, because HPV is prevention of a cancer for women. And we start to introduce it in Rwanda at a time where cancer was not so well known by communities. So you have to promote an opportunity of protecting, vaccinating girls, for protecting them for later, for a disease the community is not totally informed, but also for a part of the body that was not so well known by our women, the cervix. We all knew about the uterus, but the cervix, so explaining the cancer, the cervix, the injection, why before the first, etc. What took us a couple of time, not so long, less than a year. And immediately we had 93% of uptake voluntary. So that means when you take time to talk, to explain, to go to the people, to get questions, and to involve in a participatory process, teachers, local leaders, community health workers, etc., you create the trust for making the community happily protecting their children, because they love their children and they love their women. They don't want them to die with a disease if you explain that to them. So this is like HIV, it's really for me an equity agenda inside the country and globally. And the vaccine, as described by Jim, the vaccine issue now globally for COVID is really, again, an equity agenda in the country and globally, because it's not because some doses are brought in a country that it will be equitably distributed. Thank you, Sheila.
Thanks, and yes, Peter, do you want to share a little bit about the UK and any lessons learned there?
UK's been such an interesting case study because they we've gone from worst to first in a way, and it's one of the countries that I think really suffered initially from what Paul calls containment nihilism. This sort of idea that very early on the kind of decision was made that we won't be able to contain this. We just have to kind of let it rip in a controlled way through the population, and realized obviously what a disastrous approach that was. And it's one of some of those early failures in responding aggressively to the outbreak of this new infectious disease really led to some of the highest death rates in the world. I think the other big lesson in terms of negative lessons of what not to do was this kind of false dichotomy between public health and the economy, that there's always this tension between some of the restrictions on our daily life and on economic conditions to protect the public health and lockdowns as kind of a last resort, versus trying to keep the economy going through a crisis. And I think what we've learned again and again around the world is that these two things go hand in hand, and you can't have a raging pandemic where a virus is spreading uncontrollably, people are dying, people are afraid, and have healthy economic activity, that these actually two things go together. Now, on the positive side, briefly, some things where I think the UK has been a real leader. First is in research, and particularly collaborative research and scientific discovery, where folks came together really early, not just on the development of new vaccines, but also in terms of setting up very complex clinical trials to look at different potential effective treatments for folks with moderate and severe COVID-19. And that led to some really important life-saving discoveries, including things like dexamethasone, a cheap, widely available everywhere steroid drug, which could reduce mortality by about half. And that was done by mobilizing a network across the NHS and a number of universities in the UK, but also internationally, quite quickly. So I think that was really important. And then the second thing was, kind of getting a second chance. Once the vaccines finally did become available, what the UK pivoted and did was say, well, look, we actually have a really effective National Health Service, which is accessible to everybody. Let's finally build our response on the NHS. And that's what was done with the vaccine rollout beginning in December. And what we saw was actually taking the existing local public health infrastructure and using that to deploy this massive implementation effort of vaccine rollout was tremendously effective. And that just goes to the importance of having effective public health systems and then putting them to good use in a crisis.
Thanks, Peter. Yeah, definitely. I think in the US, we certainly saw that the lack of a robust public health system has delayed the COVID efforts, certainly in testing and treatment, but also vaccination. Paul, would love to hear your thoughts on Haiti and kind of where we are with this, and what is some of the other challenges being faced by Haiti and many of our other countries that where Partners in Health is working in.
Yeah, thank you very much, Sheila. And I'm just going to echo Agnes saying, it's a privilege to be here with such dear friends who we can look up to with admiration, looking back at what they've done. But right now we're focused on what we will do and what we're going to do in Haiti. I think we're seeing the same sort of mixed picture that we have seen elsewhere on the continent of Africa, for example. Sorry, loud dog. So we're seeing much lower fatality rates that are being reported across the border in the Dominican Republic. But again, without adequate national surveillance, it's hard to know just how many cases there have been and how many deaths could be attributed to Ebola. Looking back to past vaccine endeavors, Sheila, the ones that you know, as do others involved with Partners in Health, we have a number of experiences in recent years with vaccines that aren't on the schedule, but suddenly are necessary. In a way, and the analogy is to COVID-19, where there was no vaccine at all, and now we need one and have one. In the case of cholera, for example, the vaccines, the oral vaccines that we were after in the middle of what became Haiti's first and the world's most explosive outbreak, these had already gone through trials and had already been used on a population level and to respond to outbreaks, particularly in the areas where the bacterium had been endemic for a long time. So we used that approach, that is a broad-based community approach in rural Haiti with good effect. In fact, we had difficulty measuring the impact because there were so few cases among those who were vaccinated. But I really want to turn, Sheila, if I may, to the more recent experience with Ebola in West Africa, or for that matter, in the Congo. And there, I think we saw something that Jim keeps signaling to us is where we must divert our attention. Yes, to a risk-based demographic rollout based on perceived risk, but we also need to start thinking about responding to the outbreaks that will suddenly loom into view. Right now, there are just a sea of outbreaks, perhaps, in our eyes. But as the numbers go down, the question will remain, are we still going to use the vaccine only to proceed with a risk-based rollout, or are we going to use the vaccine reactively to respond to outbreaks? And as you know, and as many on this call will know, that's called ring vaccination. And that really is what stopped smallpox in the end, but it also is what slowed down and likely has stopped polio vaccination in the end. In other words, there are only a few places where there are these outbreaks. You don't go back in and vaccinate everyone in the population. You go to the outbreak and then start responding with reactive vaccine to the contacts of the confirmed cases and the contacts of their contacts. And so, again, I hope Jim will speak about this some more, but I think what we're really being called to do is also to think about what should be the structure and intent of our vaccine rollout. We know we want it to be equitable. We want it to protect the most vulnerable, but we also want it to be effective at stopping the outbreaks, without which activity we're not going to be able to claim to have stopped the pandemic.
Thanks, Paul. Yeah, Jim, if you could pick up on that, and one, if you could touch on the ringberry vaccine, that vaccination that Paul was just saying, but also about the issue of vaccine hesitancy in the U.S. And are you hearing about that? Is that something that you think is a phenomenon? And if so, what is the best ways we can address that? Or are there other factors leading into that conversation, do you think?
Yeah, Sheila, we've seen just about everything. We've seen vaccine hesitancy. We've seen even sort of, an activist anti-vaccine movement. We've seen just this crazy anti-mask kind of sentiment where people are aggressively going up to others and pulling masks off. This is just the things that have been that we've seen in the U.S. During this pandemic have just been stunning to me. And if you just think about what Agnes said about how Rwanda is approaching these 11 vaccinations, it's about neighbors helping others, caring about women and children, caring enough about your loved ones that you work to ensure that they get all those things that will keep them safe and healthy. That's actually the challenge of our time. It's a challenge of solidarity, and on what basis can you build solidarity? There are some countries that build solidarity around fighting the vaccine based on dictate, right? And not every country can do that, but in some of the countries that have done that, my goodness, the response has been effective, and the ultimate result has been that There's no community transmission in some of these places. And also the economies are booming. They're back to where they were before, which gets right to what Peter said. And we try to make this point early on. No, it's not economy versus the pandemic. The only way you get your economy back is by taking seriously the approach to the pandemic. And this containment nihilism that Peter talked about and Paul talks about, this was just stunning to us here in the United States. Supposedly the country that was best prepared for a pandemic. And I remember KJ, one of our co-workers, who's one of the leaders of the Massachusetts effort, called me and said, they're saying they can't stop community transmission in Florida, and there are 3 cases, right? So it happened early on. There was almost a preemptive nihilism. They were saying we can't stop community transmission before there were any cases, right? And so we've seen this before. And this is just, if you watch Bending the Arc, the whole movie, in fact, was about public health nihilism and about how we had to fight that every step of the way. We tried in the United States to fight it, but it was just too difficult because there were competing discourses out there. There were a lot of people in the public health community who said, you can't contain this thing, contact tracing, this is crazy, you can't do it, you just have to wait for herd immunity to kick in. And on that point, one of the most, I think, chilling conversations I've had during this whole pandemic was with Bill Foege. Bill is a great hero of ours, a mentor to both Paul and me, and the person who came up with the ring vaccination strategy for smallpox. He's the one who invented it. And the reason they had to do ring vaccination was because they realized that there was just no way they were going to have enough vaccine to vaccinate everybody in the world. And so in India, they started saying, okay, so let's just go to where the cases are. And as soon as we hear about a case of smallpox, we're going to go to that village. We're going to vaccinate everyone in that village. We're going to interview every single person in that village to find out where they've been, go to the places they've been, vaccinate everyone in those places, interview everyone in those places that the villagers have been, and then keep vaccinating around until they feel that they've got it under control. But the most chilling thing he said to me was, he said, every week my team was telling me, oh, once we get to 70 to 80% vaccination, we'll have herd immunity and it will be fine. And he said, it never happened. It never happened. There would be states where they would get to 70 to 80% vaccination and they would still have outbreaks. And they would get to, and in places where they had very aggressive management of outbreaks, they had only 7% vaccination and there were no cases. And so, how would this scenario work itself out in terms of the of COVID-19? Well, it's new mutations, right? So let's say you get 70 to 80% vaccinated. I mean, we hear a story of Manaus in Brazil that's really chilling, where 70% of the people in Manaus were infected during the first wave. And now with the Brazil variant, many of those people are getting reinfected and they're getting sick. So, I think that there's going to be no way around a much more aggressive public health response. And each country is going to have to find their own foundation for solidarity. Now, Rwanda, you've heard what Agnes said. When you have leaders like Agnes, when you have leaders like President Kagame, you're going to be able to find a path forward. China, Korea, Taiwan, Hong Kong, Australia, New Zealand have all found in very different cultural contexts, their path forward towards solidarity. Every country is going to face that crisis, and what we heard from some of the herd immunity mafia, we called them, was that, well, you can't do any of those things that those successful countries did because we're a democracy and we believe in freedom. This was an actual conversation that I had with one of the leaders of that group. And so I would say, well, then it's going to be very difficult. If you equate freedom with sort of these anti-mask, anti-vaccine conspiracy theories, if that's what freedom means, then we're going to have a difficult time. If freedom means not doing effective contact tracing because you think it impinges on people's freedom, then we're going to have a difficult time. I mean, contact tracing is about stopping a virus, right? And no matter how soaring our rhetoric may be about freedoms, the virus doesn't care, right? And so, and I'm not saying this is simple. It's not a simple conversation. It's not an easy conversation. It's just that every successful country, every successful community has found its own path towards solidarity. We haven't found it in the United States, unfortunately. And I think the new administration is doing great work. It's so much better than it was before. We have now a proposal. We're working actually with Bill Foege, based on the Partners in Health experience, about something that we're calling tactical immunization. That's exactly as Paul described it. I think that's what's needed. I mean, I think you've got to, instead of vaccinating everyone who falls into the demographic criteria in rich communities where there's no virus, you got to go after the communities where there's a lot of virus and vaccinate those people, regardless of where they fall demographically. This COVID-19 is a big solidarity test, and boy, so many of the countries that were so confident of their ability to fight a pandemic are failing miserably.
Thanks, Jim. I'd like to loop back to you, Agnes, because I was struck by, we talked very often during this past year and hearing about the Rwanda response. And, we were very proud that within the Massachusetts program here in the US, we built in care resource coordination. So the ability to make sure people had the social support they needed to isolate or to care for themselves and have food and safe housing, et cetera. And you described to me something in Rwanda where it's very much community by community, and it's just built into the fabric. And during pandemic times, but not. Could you talk a little bit about that and how you think this has influenced Rwanda's ability to respond?
It impact a lot, Sheila, because the US have proven that you can have the best health infrastructure, modern one, on earth and miserably fail. Just because you don't have the best community cohesion. And that's a debate we need to have after when we have all passed through this pandemic, because we need, it has to be based on trust, Science goes so fast. How many times that even the best educated people take their phone and call people across the world and say, tell me, I hear this, what it is about. We don't know. It's a new disease. We had to learn so much. However, we knew what it takes to stop the spread. We knew how it takes for vulnerable communities who cannot stay home in a lockdown because they don't have food to put on the table. What it means. So that means if you take measure for the entire nation, you need to be focused on the most vulnerable first to make sure that they can cope with those measures. If they need to have food for their children, if not, why do you want that the poor are going to die because they don't eat for the nation to survive? No way. The nation will be together in a cohesive way if we take care about the vulnerable. And some societies that are led by self-centered people didn't understand that. They believe that if they save the well-off, it's enough. No, it will be enough if you save the poorest, if you save the most vulnerable, so that everybody can come together. And we need also to think about what is democracy, I totally agree. If you understand that you don't believe in masks, you have a big scientific problem. But if you are pushed to that for political reason by selfish politicians, this is not democracy, or I don't want it because it will kill me. So that means there is a responsibility that goes with democracy, that it's to tell the truth for the good of the people and to do the best for the most vulnerable of your community when you pretend to save a nation. So this is what we did based on science, identify when the norms and procedures were issued by WHO, CDC Africa, scientists across the world. We see what it takes, lockdown, what is the risk of lockdown for the poor and for the vulnerable, and what to do with it. Thank you, Sheila.
Thanks, Agnes. So we've talked about the root cause of where we think this inequity sits a little bit when we first started the conversation. And then we've talked a little bit about the transnational learnings and where can we take what's happened and successes of the UK, later on Rwanda, through different pieces. So if we look at how do we have resiliency in our global community and in terms of education advocacy, what does that look like? What do you, and I'll go to Paul first, what do you feel we need to be focusing on in terms of education advocacy, or what are the key components so that we're having more resilient global communities?
Well, I think that the lessons that Agnes just brought up, she mentioned that if you pretend, meaning if you want to protect your entire nation, focus on the vulnerable first. There are ample epidemiological reasons, there are political reasons, but I think what is being underlined is that there are social reasons as well, and that if you care to build social cohesion, unifying around protecting the vulnerable is also an important thing to do. And she and others credit some of Rwanda's amazing recovery, which is better than resilience, and I'll go back to that in a second, to a growing social cohesion that stem from in part the way they rolled out healthcare delivery programs and education across the nation in the last 15 years. So I regard that as a powerful clarion call moving forward. And again, there are other more technical approaches regarding, whether we call it reactive vaccination or something else. We really have a long way to go on that front as well. Now, if I could just say something that sounds a little bit cranky about resilience, it's a metaphor, right? It's taken from material science, the idea that something springs back to its original form. In this instance, we are not at all interested in springing back to our initial form. We want to spring back into another form that is more protective, safer for those communities we love, and the unknown stranger as well. And so, this is one reason to keep going back to the material as well as the social. The social is a discussion of social cohesion inside a community. What does democracy mean, et cetera. The material helps us get back to staff-space systems and the adequate support that's required to go from this hunkered down mentality where we're facing either clinical nihilism, there's nothing we can do for those people, or containment nihilism, it's too late to stop the spread. To go from that to something resembling a very effective and definitive COVID response requires probably chucking the idea that we're trying to get back to a form that we previously had. Again, I don't think this is the time or place to be griping about the term resilience. As a metaphor, I get it, but we're really looking for something much better than resilience. The ability to take new forms socially, medically, and in terms of responding to pandemics.
Thanks, Paul. Agnes, as we look at what role does education play in this current pandemic response and looking forward, what can you speak a little bit about that, of what you see those foundational pieces are and where we should be heading in that direction.
So, Sheila, we are all here in this panel working together for equity. And the University of Global Health Equity is the only one have equity inside of its name, or what everything we are. I think education across curricula need to have an equity focus, meaning how to help the most in need for whatever we do. So this is something that is everything I have talked about what we have achieved in this country and what we teach at UGHE. But COVID is an example of a one health threat, a virus coming from an animal or someplace, whatever, and there will be others. We have Ebola, we have others. And if our doctors, nurses, health program managers, health leaders doesn't know how, at least where to ring, what type of help to seek, what type of program to work on in a multidisciplinary fashion, next pandemic, we will do the same mistake. There are some countries that will make it because they are used to work like that, and others will still continue to argue. So focus on science, educate in a multidisciplinary fashion. One health across all curricula, and also prepare your doctors, your nurses, and all the people who are people who are leaders in political sphere, national or local, and we teach people of that caliber how to be prepared and to respond to an outbreak locally, but also to contribute internationally. It helped going. So this is what we do at UGHE for this type of problem. And we have done that together as a bigger family, as partner in health, with the preparedness and response curricula that we have done together. It is not it's not an addition. It has to be embedded in the primary education we give in the health sphere. Thank you.
Thanks, Agnes. Paul, do you want to say a few minutes about social medicine? How do you see that intersection with what Agnes was just talking about? And is there a distinction or is there similarities in that approach?
Thank you, Sheila. You know, Jim and I trained in this tradition of social medicine. And, you know, it really encompasses very easily the whole concept of One Health. It is, you know, a broadly ecological take on epidemics, for example, or other health problems, whether they're communicable or non-communicable. And I think that really the only difference is that there's more of a tradition in social medicine of looking very carefully around at context, usually through anthropology or sociology or some other socializing discipline, and then looking back in time at social history. And for me, the One Health approach also calls for that kind of broadly inclusive analysis. And I'll just give an example, Sheila, from our discussion today. You know, the claims that certain new variants are more infectious or more virulent or both, you know, are very, very difficult to assess, right? The story from Manaus that Jim gave us is extremely troubling. It is okay to have kind of a hermeneutic of suspicion towards rapid claims about increased virulence or increased transmissibility, but we don't want to be so skeptical that we're going to miss something critical. And how would you understand in a setting in which there are so many changing gears, ongoing vaccination, faltering, sometimes faltering public health measures like social distance and mask wearing, rapid movements of population? I'm just thinking about Manaus, right? How would you possibly, you know, offer a reasonable analysis of what's going on without understanding molecular biology, viruses and how they're replicated, human behavior, historical underpinnings of that behavior, future constraints, or changes being imposed by a rapid countermeasure called vaccination. It's so confusing. And a lot of us who do social medicine think, yeah, I like studying that kind of mess, because we can make heads or tails out of it if we have the right analytic tools. So thank you, Sheila, for letting me, make a little plug for social medicine. Everybody at UGHE has embraced this way of learning, and it fits very well with the One Health paradigm.
Thanks, Paul. We just had a question come in that I would actually, I'm going to ask Peter to respond to before we kind of wrap up this session. And the question was about what is our current global understanding of the ways that we have found to address impact of COVID on non-COVID health-related care delivery, like surgical services, maternity services. Are there things that we have learned in this that we should be, including in our work moving forward, or any comments do you have on that?
Yeah, it's a great question. We've seen, all over the world, a number of different settings, health systems be really overwhelmed. Of course, we've seen the stories, whether it's in Italy, in the US, elsewhere, of ICUs exceeding capacity, of, doctors and nurses having to make horrible decisions about rationing ventilators and things like that. And what's happened in the backdrop, of course, is that, access to services for virtually everything else in some of these settings has really gone by the wayside. So people aren't getting screened for cancer, that in low and middle income countries, that sometimes vaccination programs are faltering. All the gains that have been made over the last several decades in progress with AIDS care and treatment, for example, which requires reliable, consistent supply chains and delivery of care. All of that stuff, can be under threat in a crisis. And maybe this gets a little bit to the talk about resilience that Paul and Agnes were talking about earlier. I think what it comes down to, first off, is having an effective community-based primary healthcare system, that's functioning first and foremost, because that allows you to have the platform to sort of walk and chew gum at the same time. And then the second thing, obviously, is to be able to respond effectively. So I think we sometimes forget, and Jim pointed this out earlier, that there are parts of the world that were able to respond quickly and keep the virus relatively contained and sort of get on with life. And so the importance of having public health infrastructure in place to be able to respond to a new threat quickly can allow you to protect the rest of your health system as well. Beyond that, obviously, there's been a lot of progress in, things like remote consultations and using technology to be able to provide some types of care at a distance. And that's great. And in some ways, we may see that prove to give us ways to improve access to things like mental health services and other places where accessibility has been limited. But that sort of technology will never replace, obviously, face-to-face care.
Thanks, Peter. I want to jump to Jim, and this is one of the questions that had come up prior, that when you were at the World Bank, you spearheaded the development and rollout of the Human Capital Index. How can the same emphasis and accountability be applied to leaders of rich countries stockpiling up to 6 times of the needed doses while we're still claiming to have equitable health systems? Can you speak a little bit about that?
Well, Sheila, I think this whole conversation has made clear that we don't have equitable health systems. And I think we know now that we don't have equitable health systems, in most of the OECD, most of the rich countries in the world. And whether it's in northern Italy, where, just huge numbers of older people died, people in nursing homes, the equitable systems don't exist. But the Human Capital Index, I have to say, I have to once again, as I always do, pay tribute to Agnes, who taught me about how lists can both make people furious and then make people act. So Agnes, the first time I met Agnes, she was scolding me because we started something in 2003 called the 3x5 initiative, trying to get 3 million people on treatment by 2005. And Agnes at that time was head of the HIV program in Rwanda. And she basically said to me, who the hell do you think you are, WHO, to set a goal for us without giving us the kind of support we need to be able to treat our people? Exactly the right question. And so for us, setting the goal and measuring the number of people on treatment in the countries was an irritant to the system that we hope would lead to a much better response. And the good news is that that's exactly what it did. It did lead to a much better response, but the WHO had to play an extremely important role in getting that response going. So one of the things that we had to do was we had to figure out a way to get generically manufactured antiretrovirals into these countries at the time we were thinking between $200 and $300 a year, whereas in the rich countries, the cost of HIV medicines was well over $10,000 a year. And so the way we did it was we used the WHO to essentially be the drug regulatory authority for the entire world. And the WHO would go to the Chinese and Indian and other factories, quote unquote, pre-qualify the medicines and then get them out there so that the Rwandan health system could import those drugs and feel confident in their quality. So we had to do all kinds of things to enable the process. And so it was that lesson. What I learned was that there's nothing like a ranked order system to get people riled up about what they're doing. So we put this system together that said, that asked a very simple question. If you took 4 or 5, and now I think they're using 6 indicators of health and education, health and educational status, do those correlate looking backward to economic growth? And what we found was that if you looked at these 4 or 5 factors, they're very simple. The most important one, it turned out to be something we call learning adjusted years of schooling. We have so much data now on testing that we really know what 1 year of schooling is worth in countries around the world. Singapore has the best educational system. Unfortunately, many countries in Africa are not so good. One of the countries we work in, Malawi, rates very low on the scale. So if you take learning adjusted years of schooling, you take childhood stunting, you take child mortality, adult mortality, that's just 4 indicators. Those are among the most powerful predictors of economic growth looking backward that we'd ever seen. So that's why we put it together. And the hope was that it would stimulate countries to say, oh my God, look, we're ranked behind this country that we've always felt superior to. How is it that we're behind this country that we felt superior to? We knew that these kinds of rankings would cause political problems for leaders because it would be in the newspapers. They would say, hey, how is it that country X is below country Y? There must be something wrong here. And again, that's exactly the impact it seems to be having. And so that's why we did it. Now, getting to this next question of stockpiling, Sheila, I think we got at it earlier, but the entire structure of aid has been just completely thrown off. And that's because, let's take, for example, the United States. When you've engaged in something like $5 trillion of fiscal stimulus and are in a situation where there's really very little room in the budget for things like, aid programs, it looks like the Biden administration is really committed to continuing its aid program, but it becomes very difficult. I mean, the UK made this incredible pledge under David Cameron to get to 0.7% of GDP. I think they've gone back on that, Peter, if that's okay, just because they said we can't do it, it's too difficult. So, the human capital index, it'd be interesting to see where we stand now, given the coronavirus outbreak. But coronavirus has effectively, COVID-19 has effectively taken apart the structure of how rich countries help poor countries. And it's absolutely reflected in the stockpiling of vaccines, right? And as I said before, there's just very few countries that feel, hey, we're on top of it, all good here. maybe New Zealand, having open concerts where no one's wearing a mask because they feel like they've got, community transmission under control. Maybe that's the one country that feels pretty comfortable right now, but just wait. That you could have an outbreak there at any moment. I guarantee you that the New Zealand health authorities know that. So this is unique, and it's not only taking apart the structure of individual countries, but it's already taken apart the traditional structure of how countries help each other. And I think that what Paul said about bouncing back to something better, I think that's what's on the table. What's that going to look like? And I think one of the things that's going to happen is Africa is absolutely last in line for the mRNA vaccines. And although it's, you don't hear that in polite global health circles, that's exactly where we are. So I think what it could and should lead to is manufacturing capacity in Africa that we've never seen before. We could not realistically talk about manufacturing capacity in Africa reaching the level that it needed to for antiretrovirals in 2000. Certainly not in some of the poorer countries, but now we can. And that's new. And I think now it's not lost on anybody among the African leadership that that's the direction we have to go.
Thanks, Jim. Switching gears a tiny bit, Peter, you've spoken recently about ethical issues around vaccine passports, and as we've, the world wants to get back to kind of global travel. What are your thoughts on what the vaccine passport, whatever that might look like, is, and what are the issues that's going to carry forward in terms of equity, since we know that there is obviously challenges within that? So can you speak to that?
Yeah, sure. It's something that comes up here all the time, and it's a technological, ethical, regulatory minefield, but I think it's going to happen regardless. And so I think we're wise to think about how it can be done effectively and kind of what it's for. First, it's based on the premise that, vaccines effectively can interrupt transmission, which we have increasingly optimistic evidence that they can, but still coming in. Second, this isn't necessarily new. All of us here in this conversation today carry around a little yellow vaccine passport, our yellow fever, vaccination certificate from WHO, which is required to enter certain countries if you've traveled to certain other countries where yellow fever is endemic. So, there is a precedent for this. The question is, who's going to certify, this, and then particularly what's it going to be used for? And I think that for instances like international travel, it may make sense. Potentially for mass gatherings and those kinds of things, it may make sense. It gets a lot more complicated if you're talking about the use of vaccine passports or whatever you want to call them for sort of day-to-day life. The big question, though, comes down to, is this going to be a carrot where, you can encourage the idea that vaccines are a passport to getting our freedoms back and getting back to doing the things we love, or is it actually going to further amplify disparities? And that comes down to, does everybody have access to this vaccine or not? So if you start rolling out vaccine passports in a place where people under the age of 40 aren't eligible to get a vaccine yet, you're effectively excluding them then from participating in certain activities in society. We know that a lot of even the so-called vaccine hesitancy in some communities, especially poor and communities of color, comes down to actually structural barriers to receiving vaccinations in other historical issues. Unless we've overcome those things, then I think this also gets much more complicated. So it's not an easy question to answer, but I think that this era is coming. What I really worry about over the long term is that we're, maybe by the end of 2021, going to be entering this really bizarre two-tiered world where wealthy countries have largely brought things under control through widespread vaccinations, have largely opened back up and are getting back to normal and having concerts and having parties and having travel corridors between countries, and that the rest of the world is still waiting on the outside for access to these desperately needed vaccines and are not even allowed to travel to countries and to participate. And that is going to be, I think, a really strong illustration of the way that the pandemic has exposed, global inequality.
Great, thanks, Peter. Agnes, I'd like you to talk a little bit about, obviously we're learning a tremendous amount during this time period, as we have in the past, and as Bending the Arc, showed us those pathways. In terms of what role you see implementation science has played, maybe in other global health efforts that you've worked on, and where do you see this fitting into what we're being able to learn from this period of time, so we're, as Paul says, bouncing back better from where we started in 2020?
I hope we have learned. I'm not sure that all the people who need to learn have learned. That's my problem. But implementation science, we do it since years, but putting organization around what we do so that people who are working can win time, it should be. It's part of everything we teach also at UGHE. That means when before we were saying know your context, your epidemiology. It's part of that. You have to know the society where you want to implement an evidence-based intervention, because it's based on science, who you want to reach, what are the contextual constraints to reach them, and what are the contextual factors that are helping you to implement your program. So this is absolutely needed. And for the vaccination for COVID, it's an example. How many countries got a 1,000 of vaccine in a container without knowing how to move them? When people were dying. So that means you need to know what you want to implement, to who, what are the contextual factors, and also why those people, who are the target population to be reached first to save the maximum life. And also, when we talk about trust and vaccine hesitancy, we all know where it comes from. So working on that before, it's also something that you have to do. So what we call implementation science is because we know now there is a science behind, because you can replicate what is done. You can do theory behind that as much as you do theory for gravity in physics or the force of whatever. And I advise that we should not be somebody working in leadership without knowing how you are going to implement and what the people who work for you should do for the program to be a success. So it concerns everybody. It concerns all the sectors. Thank you.
Thanks, Agnes. So Paul, as we look at, your work, Jim's work, everyone's work, and the work of Partners in Health around what we've been able to do around the world in HIV and drug-resistant TB and in treating cancer for the first time, has been centered around building trust and being there for the long haul, and our accompaniment model certainly. How critical do you think the issues of trust is, and building emphasis on working with local partners for us to have an equitable vaccine distribution globally? And any thoughts on where we can apply those lessons learned that we saw in Bending the Arc, and also from what we've heard today?
Well, it's another one of those tough questions that we seem to be colliding with this morning and this afternoon in Rwanda time, because no one in their right mind right now is going to say, hey, trust doesn't matter. We all know that that's not the case. But we've also heard again and again that we should have reason to doubt facile diagnoses of vaccine hesitancy in the face of very significant structural and historically given reasons to be hesitant. And so the question really becomes not, is trust important, but how do you build trust? And I don't think, that you do it by going out with bullhorn into a marketplace and, giving a speech about how trustworthy you are. You do it through humble service in the manner that Agnes underlined, with a particular focus on the vulnerable, right? And if you put that time in to service, again, I said humble because I think one of the biggest problems that we run into is not, cultural competence, but a lack of cultural humility. And I just think during the Ebola outbreak in West Africa, when there were an average of 10 attacks per month on Ghanaian Red Cross vehicles in the burial teams, the folks who were giving the medical services directly had, I think, good reason to believe that we would not be attacked in that manner, and we weren't. And that's not fair to the burial team because their services were just as needed and, were able to prevent a very large number of a very large amount of ongoing transmission. But it's just not the way that you build trust. We're lucky, having a vaccine rollout that is focused on equity, that pays attention to staff, space systems, and support is much more likely to generate more trust than a bunch of public service announcements on the radio. Now, I'm for the public service announcements on the radio, don't get me wrong. I just don't think that's the primary means by which trust is built. Trust is built through service over time. And the happy news is we have a lot of work to do, as Agnes said earlier. If we stick with that service, visible or not visible, I think we'll be rewarded with more trust. And that is the way to bounce back better too, to build trust through service.
Sheila, can I jump in for just a second? One of the great lessons of Partners in Health is that, instead of having elites scratch their head and say, how can you build trust? We've sort of come in and said, well, what are the networks of trust that already exist? And actually hired community health workers, paid them to do some of the most difficult work. And I think one of the lessons we've learned is that you never know if people, especially poor people, are going to trust what politicians say. You just never know. But you know that the people that they're most likely to trust are their neighbors. Now I think that insight works potentially in every country in the world. And so, in even the richest country, even in the United States, one of the ways of getting vaccines to every community is to actually hire people from those communities to be, we have now people who are dual contact tracers and are helping to get vaccinations out. Why wouldn't you do that? Because economically, it makes perfect sense. At the World Bank group, we showed again and again and again that if you go into poor communities and give people cash, whether it's conditional on something, usually the conditionality is things like your children have to be in school, we're going to check their nutritional status, and you have to go and learn about public health. Those are the kinds of conditions that were put on, or even unconditional, like in Malawi. I mean, there was good evidence in Malawi that unconditional, just giving poor people cash, had a really positive impact on so many indicators that, if you build programs like that, where you actually give cash to people from these communities that have been isolated or, for example, or neglected, that you can do lots of good things, including stimulate the economy. Because, two fundamental insights that the World Bank did 40 plus studies to figure out. One, the answer to poverty is actually money, right? And it took 40 studies because it was so ideologically against what the World Bank had been saying. You don't give poor people cash. But it turns out that a good way to end poverty is to give people cash. And the other thing that we learned is that it acts as fiscal stimulus. Poor people spend their money and it stimulates other parts of the economy. So there's a lot of really good potential solutions that Partners in Health have been demonstrating for a very, very long time. It's not about, dressing up Tony Fauci. I trust everything Tony says. Tony Fauci in the United States is just such a great communicator, but not everyone's going to trust him, right? But people may trust their neighbor. And this could, the hope is that this could lead to an explosion in interest in public health as a career. What a great career. I know that public health school applications are going way up, which is a good thing. I'm sure UGHE applications are going way up, which is also a great thing. There is a potential for a really great outcome here. Trust is no longer something that comes from on high. Trust is something that comes from within communities. And the way to do that is by paying poor people, paying people in these communities who are not working to engage in these activities that are going to help us stop the pandemic.
Thanks, Jim. Agnes or Peter, would love to give you the opportunity if you have some last parting words before we wrap up.
Sheila, I just want to say and remind that trust, we don't build trust in the middle of a war when people are distressed. So it's a day-to-day work and a day-to-day something we build on day after day by doing the right thing for the community we want to serve. And as Paul said, they feel it, they know it, they will never attack you. They attack those they believe come to continue to harm them. And also, when you talked about implementation science, implementation strategy, I advise all the leaders to go and read about this. And we didn't get time to talk about accountability, but this is crucial because so many people died because of the lack of accountability of many of the leaders of the world. So say, as Jim have said, the right way to do things has been highlighted by COVID. If COVID has shown and highlight the inequities and what is wrong in a health system or in a country management, that it has also highlight the right things to do. And for this, yes, Partner in Health, UGHE, and all our friends have high respect today than before the pandemic. But as Paul says also, we still have a long way to go.
Peter.
Thanks. Hard to follow all of that and not too much to add. I guess just to say that, the one thing that I think we've seen again and again in communities and places and countries that have been successful is when they've made it a whole of society effort. And we've heard this, expressed beautifully from Agnes about Rwanda. I think it's true in, it's true in Taiwan, it's true in New Zealand, and it's true at the community level as well, that we're actually able to pull together to solve problems like this. It's really the only way forward. And, we will get through this, this pandemic. I think that, again, going back to this idea that this is a dress rehearsal for 21st century problems, we need to figure out how to pull together to address really complex issues like this, whether it's the next pandemic, whether it's climate change, whether it is figuring out how to save liberal democracy. And so I hope that all of these lessons that have been expressed today are things that we can carry forward, not just for COVID-19, but, as Paul said, bouncing back better. I love that term, by the way. Thanks.
Great, thanks everyone, and certainly want to thank Agnes, Peter, Jim, and Paul, as well as the amazing UGHE staff that have, I think, continued to provide a forum for these really rich conversations that don't have all the answers. I mean, we don't have all the answers, and I think if we sat here and pretended we did, that would obviously be a false pretense. This is, I think we talked a lot about today about the issues of the root causes of the inequities we see today, where there's, transnational learning. What can we learn from the best from what's happened in Rwanda, New Zealand? If there's things in the UK or the US that have worked, what are the mechanisms in which we can be sharing those lessons learned and putting pressure on our governments to be accountable, as Agnes said. I think that's going to be key. And it's going to be critical, I think, that all of us are paying attention to what is happening in the world, even when many of us will be fortunate enough to be vaccinated long before others will. I encourage everyone to watch Bending the Arc on Netflix if you haven't seen it. It certainly is, traces this really, story of what can happen when things that seem insurmountable are addressed and can be overcome. This recording will be available on the UGHE website as well as other places, and that will be communicated. And we're certainly very appreciative for everyone who joined us today, and encourage you to continue to monitor what's happening at the University of Global Health Equity, is also at Partners in Health, as we look to struggle with these things, but also change the world so that this doesn't have to be our common denominator for years to come. And I think the bounce back better will be our tagline. So appreciate everyone today and look forward to further discussions. Thank you very much.